And welcome to Team Patient Podcast. Today's topic is going to be about capacity versus competency. This is a word that often gets confused in the medical industry. This is a very important podcast to listen to if you or a loved one is in the hospital or managing a chronic illness, and potentially they have a psychiatric diagnosis or potentially moments of not being clear. And it's important to note that you can't take advantage of a person when they aren't clear. Let's say a sundowner who is not as lucid in the evening. You should always look to restore their mental capacity, to review decisions on treatment plans with them, because that honors the ethics principle of autonomy. Autonomy is pretty much the main principle, and it trumps all others. When it comes to making a decision, the defense of it's my determination, it's my self-will, it's my free will to make this decision. Self-autonomy, or patients' right to self-determination, patients' right to make decisions, is critical. Of course, making decisions requires also being informed about the treatments, options, which also include not getting treatment. So let's get back to capacity and competency. It's important that people, patients, families, and medical staff understand that capacity is a medical term. When a person is assessed for capacity to make decisions, that is something that's assessed by physicians, not just psychiatrists, but physicians, registered nurses, and certain licensed mental health professionals like myself. However, when it comes to a court hearing, judges would prefer to have some documentation from a physician, because of the MD, about capacity. And technically, capacity should be assessed for each decision. I may have the capacity to choose what I want for lunch, but I may not have the capacity to decide that I need a surgery. So capacity is not they're alert, awake, oriented times 3. They know the date and the president. So yeah, they're good to make their decision. And just because they may not know one of those things, for example, people that have been in the nursing home or the hospital for a really long time, they get like this thing called fog, and they may lose track of the day. And sometimes I've seen people try to manipulate that as they're not capable of making their own decisions. No. You can't just jump track about that. There are many dimensions to cognition that can identify capacity. And mostly when I'm talking to a patient about capacity or trying to look and find out their mental acuity or whatnot, I'm looking into what do they know, and are they able to connect ideas together that would make a good explanation for a sound decision. So the other term, competence, that is a judicial term. That is a term used in the court of law, and the only professional that can determine incompetence or judge on competency is a judge. Now, granted, the judge will rule on competency, let's say, in a guardianship legal case. That ruling is going to be based on healthcare professionals' assessment on capacity, okay? So do not confuse capacity for competence. So I'm going to read an excerpt from one of the articles I wrote, a case example. An African-American male in his late 40s, we'll call him Joe, has a history of schizophrenia, uncontrolled diabetes, and one leg amputation above the knee. His other leg has a large infection. He is homeless and reports having no outside supports. This is one of very typical cases that I will deal with, but know that not everybody is so severe. But to illustrate capacity and competency, I chose this case example to really define those lines. So Joe, the patient, disagrees with the recommended treatment, and he wants to attempt to fight the infection with strong IV antibiotics. Now, his decision-making capacity was put into question by the surgical team, and thus they ordered a psychiatric assessment. And their argument was he's not capable of making the decision. He has schizophrenia. He's not really thinking this through. There's no guarantee that the strong IV antibiotics that he will be on will actually kill the infection, and thereby the infection could be deadly, and he could actually die. If we amputate his other leg, no, remember he already has one amputation. If we amputate his leg, then we cut the infection off at the source, and that way we're guaranteed to contain the infection, and he won't die. And so doctors will often reason their ethical oath of to do no harm, but to do no harm is very subjective. In Joe's case, maybe you have to interview a person. You have to understand their value set to know whether or not you're doing harm. This surgical team, their thought is to do no harm. Don't want to take any risks at all of the infection killing him. So we're gonna have people say that he's incapacitated, so that we can do a 3-physician signature and go ahead and take him to the OR, even though he doesn't want to, and go ahead and do that amputation. Except the psychiatrist, the neuropsychologist, and me, the social worker, we all agreed that he's completely capacitated for making this decision. And for me, what was clear and what I explained to the surgical resident, I said, what you have to understand is he's showing insight into his decision. And they're like, but he's got schizophrenia. I said, it doesn't matter if he has schizophrenia. Okay, what matters is his mindset right now. And to me, it's a very sound decision because, listen, he's homeless. And he said, if there's one thing worse than being homeless with one leg, it's going to be homeless with 2 legs. He said, I'd rather be dead. He wasn't suicidal. He was just saying that the quality of life that he would be willing to lead is not one of having 2 legs living on the street. And that's his birthright. It's his body. He rules over his body, and he decides what level of stress or strain he could live under. Just like some people decide, you know what, I don't want to go through chemotherapy. I just want to allow natural death. For him, and I said, well, are you aware what will happen if you get the IV antibiotics? He was clear. He said, yes, I know I could die because the antibiotics may not kill all the infection, and the infection will end up taking over my body and I'll die. But I would rather die than live on the street with no legs. And he makes a good point. He said, do you know what it's like to live on the street? No. Do the surgeons know what it's like to live on the street? Living on the street with 2 legs, much less 1 leg, and you're telling me go get an amputation and be without both legs and be legless, that's not a life that I want to lead. At that point, I want God to take me home. All right, well, that's very sound, and so together, the neuropsychologist, the psychiatrist, and me shouldn't have to take all 3. We basically explained to the surgical team that he's making complete sense, and they're like, well, as long as and this is often the case as long as I'm not acting with maleficence, which is an ethics term about acting with intention to do harm. It's like, well, no, you're not acting with harm. You consulted the psychiatrist. Like, you're doing everything. Just because in your mind the right decision is to amputate, that doesn't mean you're acting with harm. You're actually acting with beneficence because you're concerned that the IV antibiotics aren't going to work. So, hence all of this conversation. So, long and short, it turns out that he was discharged from the hospital, transferred to skilled nursing, and he did receive the IV antibiotics. I don't remember how many days it was, but I actually ran into him probably about 8 months later, and I said, I don't think you remember me, but I said, it's great to see you. I said, how did the antibiotics go? And he said, great. He said, it killed the infection, I'm infection-free, and I got to keep my leg. Now think about that. The physicians, the surgeons, assessed the infection. They presented the solution. He didn't agree with the solution. And there's a quick, oh, he's got schizophrenia in his past medical history. Schizophrenia does not equate to not being able to make decisions for yourself. Not even close, okay? I literally had 3 neighbors that were diagnosed with schizophrenia that I grew up with on my street. And it's not even the case, all right? Everything is a one-by-one case. So in this situation, while it was a little annoying that Joe's capacity came under scrutiny because of schizophrenia and because he did not see eye to eye with the surgical team's recommendation, that's a little frustrating, but that happens every day all over the country, all right? The patient and the physician are supposed to work as a team together. As it turned out in this situation, the mental health professionals were able to act as basically a mediator to basically facilitate and strengthen communication and understanding between the surgical team and the patient. And, we're evolving, but I hope there will come a time where doctors can communicate directly with their patient and truly understand the sound judgment that goes into decision making, regardless. Either way, all's well that ends well with that case. And you have been listening to Team Patient Podcast. I'm Karen, the social worker, your host, and I will have one podcast per week that will be useful for patients, patient family members, individuals who maybe are managing a chronic illness, as well as nurses, doctors, and other healthcare professionals to help understand the complex healthcare system and how patients can sometimes get lost, and without advocates, sometimes very unethical, undignified things end up happening. So I'm not trying to scare. I don't believe in scare, like fear porn or whatever. But please continue to tune in and learn better how to advocate for self, family, loved ones, as well as patients.